All right, good afternoon, everybody. I was asked to get started at 1:30, and it is 1:30, so we'll go ahead and get started. For starters, I will introduce myself. So I am Dr. Faith E. Hekwazu. I am actually a gastroenterologist at Texas Children's Hospital. So you may wonder how did I get here? I am very blessed to work very closely with our Bluebird Rett Center at Texas Children's. And under that umbrella, we see patients with Rett syndrome, MECP2 duplication, FOXG1, and importantly, all of our CDKL5 Deficiency Disorder patients. So we have a multidisciplinary clinic that Dr. Suter had mentioned yesterday, I believe it was, and I also see them in clinic, my own clinic, kind of in between when necessary. So when Karen invited me to come and talk with you all, I was very excited. So I definitely want to thank Karen and all the organizers of this amazing conference. I don't have to tell you all what an important role the GI tract plays in our friends with CDD. So today, first and foremost, I have no really relevant disclosures. I do some consulting for Acadia Pharmaceuticals, but nothing relevant to today. So what I am hoping to do today is I will go through and sort of describe the nutritional and GI problems that patients with CDD tend to deal with. And I'll discuss some treatment strategies, sort of how I think through these issues for both the nutritional side and the GI problems. I intentionally left some space at the end for questions, so as I'm going through, you're certainly welcome to raise your hand and ask a question then, but at the end I'll definitely have some time. So if you guys have questions, please feel free to ask them. So 87%, so 90% basically of patients with CDKL5, and I would venture to say maybe even more, are reported to have issues with GI symptoms. So those can range from constipation, nausea and vomiting, gastroparesis, which is just a delayed emptying of the stomach, dysphagia, which is the fancy medical term for difficulty with chewing and swallowing, abdominal bloating, and malnutrition / failure to thrive, which some people may hear or see in their medical records. So starting with constipation, this is the big one. Over 70% of patients with CDD suffer with constipation. And what is constipation? It's just difficulty with having bowel movements, exactly what it sounds like. So that could be defined by infrequent bowel movements, so less than twice a week. Hard stools, you can have a poop every day and still be constipated. Hard stools, sometimes we see blood in the stool. Kids who really struggle just to push the poop out, and that is something we can see. The poop is soft, but we just have difficulty getting it out. Abdominal distension, often when we are full of poop, we are also full of gas, and so the belly can get very big. Pain, people underestimate how incredibly painful constipation can be. Phletus, which is just passing of gas. So again, that poop makes us very, very gassy, and that gas can be very stinky, as I'm sure many of you have seen. Urinary tract infections. So something that a lot of people aren't aware of is that one of the most common causes of bedwetting in neurotypical children, and for the same reason urinary tract infections in both neurotypical children and other children, is constipation. So it can cause more problems than just pain. Feeding refusal, when our belly's full of poop, we don't really want to eat. Vomiting, and as was mentioned yesterday, constipation can worsen seizures for some children. So what do we do when I see them in clinic? Rectal exam, I'll be honest, I don't do very often. Kids don't tend to love that. And it doesn't often give us that much information, but it is a possibility, especially if I'm concerned for a hemorrhoid, if there's been blood in the stool or something like that. If we aren't sure, sometimes I will get an abdominal x-ray. That's sort of an easy way to see is someone full of poop. And sometimes the story is a little bit gray, and families are describing, well, they only poop a few times a week, but it's soft, it doesn't seem that bad, but we're distended. And so if we aren't sure, I will get an x-ray. And then barium enema, that's a contrast study that can actually give us a lot of information about the anatomy and things that might be contributing to constipation. So what do we do about constipation? So easy fixes, easy. I'll put an asterisk next to easy. None of these are easy. Fiber, making sure that kids are getting enough fiber. So that's from fruits, vegetables, cereals. For G-tube fed patients, we can calculate out the fiber they're getting from their formula and add additional sources of fiber if necessary. Sorbitol containing fruit, so that's where you hear about prune juice and things like that can really increase bowel movements. And probiotics can be helpful. Probiotics can also be tricky in that we are not at a place now where I can look at one patient and say, this is the probiotic that will be the most helpful to you. There is some data coming out about the microbiome and CDD, but not enough to really point to one specific probiotic as the key that's going to help someone's GI issues. That being said, it's one of those medicines that I'm like, or not even medicine, supplements that I don't really see much harm in, and so I'm usually in favor of trying a probiotic and seeing whether or not we see a difference. Physical activity, this is huge. So in our ambulatory patients, making sure they're getting up and moving around. In our non-ambulatory patients, physical therapy can be really, really key. Even just bicycling the legs, making sure they're sitting up, making sure they're getting in their stander. All of that can be incredibly helpful with getting the bowels to move properly. And then we get to medications, which I will say many of our patients do require some degree of medications. And when I think about constipation medicines, I think of them in sort of four different categories. So the mushers and the pushers. So there's those that soften the poop, make it mushy. That's like Miralax, which is polyethylene glycol, lactulose, milk of magnesia. And then we have the pushers. These are the ones that actually help the colon squeeze the poop around and get it out. So that would be things like X-Lax or Senna, Bisacodyl or Dulcolax. And then there's the ones from below, like the glycerin suppositories, the Bisacodyl or Docusate suppositories. So suppositories from below that kind of help pull out the poop. And then finally, sometimes we do need to get larger volume enemas in there or even do like a lavage or a bowel clean out. For those who have very severe constipation that do not respond to any of these above medicines or don't respond sufficiently, there are surgical options. They're used much more rarely, but can be truly life-changing for the patients who need them, and that includes colonic resection and a surgery called a cecostomy. And then I gave this presentation once this was actually a Rett syndrome conference, but a family was like, you didn't mention colonic massage. And they said that was the thing that completely helped their child more than anything else anyone had ever said. And so I promised them, from now on, I will always mention colonic massage, which can actually be very helpful. So you literally just rub the belly in the direction that the poop flows. So up on the right, across, and down on the left. And that can be very, very helpful and honestly can feel quite good. So kids tend to enjoy it, and it helps them get the poop out. All right, nausea and vomiting. So there's lots of reasons for nausea and vomiting. One of the biggest ones that patients with CDC suffer with is reflux. 64% of patients in the literature have GERD, and this gets worse as they get older. So what is reflux? It is just stuff in the stomach going into the esophagus, so going up the wrong direction. Things are supposed to move down, instead it moves up. This can be caused by a number of different things. So poor motility of the esophagus, if things are not being pushed down in the right direction. Poor motility of the stomach, things are not moving through, so they're just sitting there. And then we have a sphincter called the lower esophageal sphincter at the bottom of our esophagus that's supposed to function to keep things in the stomach and out of the esophagus, and sometimes it just doesn't work well, especially positionally if we're laying down. So a lot of people will notice when they lay their loved one down to change their diaper, to give them a bath, things of that nature, that's when the reflux gets the worst. At night when they sleep, for example. So what does reflux look like in a patient? It can look like a lot of things. So it can just be irritability. They're just fussy, especially around feeding times. It could be nighttime awakening. So again, when we're laying flat, gravity is no longer on our side, and so things tend to reflux up. They can absolutely see vomiting. Sometimes I hear families and caregivers describing kind of wet burps, those burps where you hear it and you know something came up and then maybe they kind of swallow it back down. Regurgitation, feeding refusal, they know it's not going to feel good, so they don't want it. Coughing, certainly if it comes back up and they don't have good control, it can sometimes cause some coughing or even wheezing if there's an element of aspiration, which is less likely but can absolutely happen. So what do we do for reflux? You can do some tests. We often don't need to because often the story is consistent enough that we can just move forward with treatment. But when we're not clear, when treatment doesn't work very well, we can do what's called an upper GI series, and this looks at the anatomy to make sure there isn't an anatomic reason that this particular person is more at risk for reflux. We can do a pH probe study, which kind of measures the degree of reflux. This is really helpful when, let's say, seizures are increasing and we aren't sure if it's because of reflux. Let's say irritability and we've got them on an acid blocker and it's just not helping. This allows caregivers to actually push a button every time a symptom happens, and then we can see at that time whether or not reflux is corresponding with that, so we can know whether or not reflux is the contributing symptom. And then we can do gastric emptying scan if we're worried about gastroparesis or that kind of slowed stomach emptying playing a role. As far as treatment, diet is always the first thing that we look at. So there are certain foods that certainly increase the risk of reflux, anything with a lot of acid in it. So spicy foods. Most of our CDD patients are not drinking a whole lot of coffee, but caffeine is something to keep in mind. Chocolate, tomatoes, so that's pizza sauce, spaghetti sauce, salsa, citrusy fruits, that includes orange juice, lemonade, any of those kind of things can increase the acid in the stomach and make reflux and the symptoms around reflux much worse. Positioning can be very helpful, so trying to keep people upright as much as we can, especially after eating when their stomach is the most full, elevating the head of the bed when we're able to. And then we get to medications, which are very commonly used. So these are acid blockers. That could be an example of a H2 receptor is like famotidine or Pepcid, and then proton pump inhibitors are things like Nexium, lansoprazole. You've probably heard of these. Prokinetics are the medicines that we use to move things forward faster. So when we're worried about the stomach not emptying properly, we may start patients on a medication like erythromycin that can help kind of speed up the emptying of the stomach, which can hopefully decrease the amount of food that's sitting there, refluxing back up. And then, of course, surgery is always an option. Not done as commonly as it used to be done, but a fundoplication where they sort of wrap the top of the stomach to prevent reflux from coming up is always an option when things are very severe. Nausea and vomiting itself, we just mentioned, can be complicated by really bad reflux, can be because of gastroparesis. Aerophagia is that swallowing, kind of gulping of air, swallowing of air. That can be quite common in CDD, and that is one of the most difficult to treat because there's not really a medicine that we can give to stop that from happening. That leads to pretty bad abdominal bloating, which can certainly increase the risk for vomiting. Seizures are a big cause of vomiting. A lot of our patients will vomit when they seize. Biliary tract disease, which I'll touch on in a moment, that's like gallstones, something that's often under-recognized, especially in patients who are nonverbal, but pain from that can absolutely cause vomiting. And then, of course, intestinal obstruction, less common, but certainly more severe. What we do for nausea and vomiting when we're not sure of the cause, we think about reflux. We do reflux precautions. We often will do smaller volumes of feed. So when you have really bad reflux, nausea, often 5 small meals is better than 3 big meals. And so if they are G-tube fed, we might even consider slower rate of feeds or even continuous feeds for a period. We will often try some acid blockers and see if that's helpful. We might do a gastric emptying scan. We might just say, let's try some erythromycin and see if that's helpful. Erythromycin can be unsafe in children who have a prolonged QT. That's a certain type of heart rhythm, so we will sometimes check an EKG first. If they are G-tube fed, often converting to a GJ where we can actually feed them past the stomach can be really helpful. And then making sure, always making sure constipation is well managed is going to be helpful with nausea and vomiting. I will just briefly touch on biliary tract disease. We don't have enough data to show how common this is in CDD yet, but we know, for example, in Rett syndrome, about 10% of girls will have some biliary tract disease. And the reason I mention it is because it's hard to diagnose unless you're thinking of it. So this is anything that affects the bile ducts, the gallbladder, anything kind of around that area. It causes belly pain, it causes nausea, vomiting. If they turn yellow, yes, you will notice it, but that is less common. Often it makes them not want to eat because it hurts when they eat. And so with that, we will sometimes get an ultrasound, especially if there's a family history of gallstones, something to always think about if we're in a situation where a patient is just uncomfortable and we can't really get to the bottom of what it is. You can also do fancier tests like MRCPs, CTs. We can do some lab work, but the ultrasound is usually the place that we start. And there are some medicines that we can use, and if found, often requires gallbladder removal. All right, moving on to gastroparesis. So again, gastroparesis is just decreased rate of the stomach emptying. The official way to diagnose this is with a gastric emptying scan. There are 2 types of gastric emptying scan we can do for children who are able to eat. The classic gastric emptying scan is 2 pieces of toast and 2 eggs and a piece of toast. Not all of our friends are able to do that. There is a liquid version. It's not as accurate. So sometimes it's kind of like if it quacks like a duck and walks like a duck, it probably is a duck. So if we are having symptoms that are very consistent with gastroparesis, that would be things like in the morning they seem fine when their stomach is empty, and then we give the first feed, they're okay. By the time that second feed in the day comes, they aren't really tolerating it as well, and then we get another one and it's even worse, and by the evening they're just not tolerating anything. So that's, you can think your stomach is filling, it's supposed to empty in time for the next meal, but maybe only 30% of it emptied, and then you give another meal, and so now it's even more full, and then only 30% of that empty, then you give another meal. So that's kind of the classic symptom of gastroparesis, although I'm sure you all know our children don't always read the textbook. That is kind of the textbook of what we would see. If we find gastric emptying as a problem, or we are very highly suspicious of gastric emptying as a problem, we will start some medicines. So the prokinetics I mentioned before, erythromycin is one of the most common ones that we start with. Bethanechol is another one that can help, and prucalopride is a third. I mentioned before we do have to beware of prolonged QT, which is again a cardiac arrhythmia. Not that these cause that, but if you have that, it can be dangerous to start these medicines, and so we want to make sure that we don't miss that. Again, similar to reflux, with gastroparesis, smaller, more frequent meals can be very helpful because again, you're giving that stomach the chance to empty the majority of what it gets instead of kind of bolusing these big, large meals. Certainly, if the gastroparesis is severe enough, bypassing the stomach with a GJ or a gastrojejunal tube can be very helpful for our patients who are already G-tube fed. And then once again, making sure constipation is managed. If the food has nowhere to go, your stomach is not going to be able to empty well, and so we want to make sure that there is space in the colon in the small bowel for the food to come down. So making sure that the constipation is really well managed can be incredibly important. All right, so let's move on to dysphagia. So what is dysphagia? It is problems with chewing and swallowing. This is something that up to 75% of our patients with CDD do struggle with. This can be something as simple as just not chewing great. You have to cut their food up very, very small. It can be as severe as they cannot tolerate anything by mouth because they aren't able to coordinate the swallow in a safe way. Features include poor chewing skills, poor tongue lateralization and bolus formations, or just not really being able to move the food around in the way that they're supposed to. Often we hear about patients who pocket food, or food just sort of pools in the back of their throat, but they don't necessarily swallow it appropriately. There can be penetration into like kind of going towards the lungs. There can be aspiration where the food or the liquid actually go into the lungs. That of course can be very dangerous. Often we see symptoms of coughing, choking, drooling, things like that can kind of point us towards the fact that they may not be tolerating the oral intake as well. And that's where we really lean on our OT and speech therapy colleagues for helping our patients work on oral motor feeding skills. We do swallow studies, not frequently, but anytime there's a change in symptoms or anytime the speech or feeding therapist feels that it's warranted because of a concern or a progression. All right, abdominal bloating. This is another one that can be quite common in our patients with CDD. So abdominal bloating is just from gas that's trapped in the stomach or trapped in the intestines. Often this gets progressively worse during the day, depending on what the cause is, but certainly with air swallowing and breath holding, which again can be relatively common in CDD, we do see this kind of progressive abdominal bloating throughout the day. As I mentioned before, constipation keeps rearing its ugly head. It can absolutely worsen abdominal bloating. If you think about it, our poop is just bacteria in our old food that needs to come out, and so you can end up with bacterial overgrowth if you are quite constipated, and small intestinal bacterial overgrowth can contribute to abdominal bloating as well. So symptoms, air swallowing, our patients who swallow a lot of air often struggle with this bloating, lots of burping, lots of distension, pain and discomfort, gas coming from both below and above, and then diarrhea can come if you have the overgrowth of bacteria in the small intestine. So tests, often it's very obvious just by looking at a patient. So we don't often need very many tests, but tests that we can consider: an x-ray, again, to see how much abdominal distension is due to gas, due to constipation, or for some other reason. Remembering that these patients are just children, and so they can have celiac disease just like anybody else can. So thinking about things that can cause abdominal distension in absolutely anybody. So thinking about testing for celiac disease. Ova and parasites, so giardia is something that can just linger if you've had any travel or exposure. And then a lactulose breath test can be, It is sort of the classic test for small intestinal bacterial overgrowth. Unfortunately, most of our CDD patients are not really able to cooperate with the breath test, and so that's where we often will just do, if it seems like it might fit the picture, we'll do just a trial of antibiotics to see if it's helpful. All right, diet. So really sugary beverages, so juices and things like that, can absolutely worsen abdominal distension and diarrhea if that's an issue. Sorbitol-containing fruits, legumes, so beans and things like that, great fiber, but can make you very gassy. Certain patients are sensitive to lactose, and so either modifying the dairy intake or even introducing a lactase enzyme, which you can get over the counter when they're going to have dairy intake, can be helpful. Certainly, if they are diagnosed with celiac disease, we want to treat that with a gluten-free diet. Anti-gas medicines like Gas-X, simethicone, Mylicon are very helpful. This is another time when probiotics can be really helpful for some patients. Again, we got to make sure that constipation is under really good control, and if it's not, we will optimize the constipation medicines to see if that can help. If we have a G-tube, that's great. It can be used almost as like a pop-off valve to allow some venting for the gas that's in the stomach. And we can use a Ferrell bag sometimes for patients who need kind of more long-term venting. Again, we like to think about small intestinal bacterial overgrowth in the back of our heads. We will sometimes do a 2-week trial of an antibiotic to see if that's helpful. And then don't forget common things being common, celiac disease, giardia, things like that that can contribute to abdominal bloating. All right, malnutrition. So malnutrition can be from a lot of different things. It could be due to dysphagia. They're not able to get the amount of calories in that they need. Aspiration or illnesses can make the caloric requirement much higher, and children often will lose weight. Genetic predisposition can certainly play a role in some syndromes and disease processes as well. About 20 to 55% of CDD children, depending on the study you look at, do require G-tube feeds. I would say in my experience, I think it's probably closer to that 55% mark. I am very blessed at Texas Children's. I have a dietitian who sees all of these patients with me, and she is very detail-oriented. So we are calculating the amount of sodium, potassium, calcium, vitamin D, protein, and calories that each of our patients is taking in, and making adjustments on the fly as needed to ensure they're getting the appropriate nutrition. I want to just mention body mass index. This is really the gold standard for determining how nutritionally replete a patient is. This is basically how big you are for how tall you are. And so that becomes really important, because if we have patients who are a little bit shorter or a little bit taller, their weight alone is not going to be a good assessment of how they are nutritionally. Normal is somewhere between the 25th and 75th percentile. If it's less than the 5th percentile, we start getting a little anxious. If it's more than the 85th percentile, we start putting you on a diet. I do want to show this superiliac skin fold thickness. So this is something that during COVID became incredibly helpful for us when many of our patients were seeing us via telemed instead of being able to come in for accurate weights. And depending, as many of you probably know, as kids get older, sometimes the pediatrician's office don't have a scale that can work with the wheelchair, or don't have a way that we can get a proper weight. And so we actually looked at this, and so basically you can see where these little calipers are squeezing. I don't expect anyone to have a caliper. I don't even have a caliper. I use my fingers. They work just as well. And what we want is to kind of squeeze that little area. If you drew a, I'm going to stand over here. If you drew a line from sort of your hip bone to your pelvic, to your like kind of down here, and you pinch right in between, people distribute fat differently. Some people it's more in their thighs, some people it's more in their stomach, some people it's more in their shoulders. But that is a place that nobody really over or under distributes fat. And so it can be when you lay your child out and kind of pinch right there, it can be a really good assessment of how they're doing nutritionally. We want it to be about the size of your finger. If you're grabbing that much, they're probably a little overly nourished. And if you can barely pick anything up, they're probably undernourished. And so it's a really good kind of marker. So you guys can all go home or tonight in the hotel room, lay your child out, kind of pinch, see where they are, and then that's where if they're in a good place, that's where you want to make sure they stay. And so we have been able to use that on our telemedicine visits. All of our families know what the skin pinch is, and they'll be able to tell us, oh, skin pinch is good, and that helps us kind of feel reassured that they're doing fine from a nutritional standpoint. If we are consistently having low BMI, if we are not gaining weight appropriately, then we start thinking about oral supplements, so formula they can drink, whether or not a gastrostomy tube might be necessary. And then, of course, if they're overweight, we're going to make some changes as well. So growth and nutritional status. So patterns of growth can really vary. We have CDD kids who are normal height. We have some that are short stature. They can have normal, poor, excess weight gain. Muscle mass is really important to consider. We can't always use the CDC growth curve for our children, especially ones who are non-ambulatory. Their muscle mass is often a bit smaller. Muscle weighs more than fat, and so we would expect their weight also to be a little bit lower, and that can be absolutely appropriate. And so we really have to sort of consider, is the weight of this person inadequate because of inadequate dietary intake, or is it just genetic predisposition? They're going to be petite and that's okay. We always want to evaluate how their chewing and swallowing is going. Are they able to safely eat the amount of food that they need to eat and drink the amount of liquids they need to drink? Are they having any symptoms like reflux, like constipation or seizures that might be impacting their ability to eat and drink the way that they need to do? So often when patients come to see me, one of their first questions is, when do we need to talk about gastrostomy? Like, when do I need to talk about a G-tube? Often in fear because they don't want one, sometimes in fear because if they don't get one, they're worried that their child is not going to be able to maintain. So the reasons that I often will consider gastrostomy, there's a number. Poor weight gain is kind of the obvious one. So we're not able to gain weight. The growth curve is just completely flattened out after they turned a certain age. We're having lots of coughing, choking, gagging symptoms while eating. Food, sometimes it's just that it takes an hour and a half to get through a meal, and it's just not sustainable anymore. Certainly, if patients are having aspiration or concerns for aspiration, certainly if they've had aspiration pneumonia or more than one aspiration pneumonia, at that point it becomes a really important discussion to have. Sometimes it's just because they're not willing to take their medicine and they need their seizure medicine, for example. Sometimes it's because they're just really not wanting to eat. They can do it, they just don't want to, and it's really hard to force that, and it becomes such a fight that the quality of life is being impacted. So it's not always children who are undernourished that need the G-tube, although that is the most common cause. There's a lot of different things that go into the discussion and different reasons that you might want to consider it. And again, up to half or more than half of our CDD patients do require a tube at some point. I will mention bone health. Again, we don't have enough data in our CDD patients yet to know, but in Rett syndrome, we do know that they are at 4 times the increased risk of fractures compared to the general population. So I sort of treat all of our patients in the Rett Center the same way, and we're very, very careful about making sure they are having plenty of vitamin D and calcium in their diet. There's a lot of reasons that our Rett patients are at increased risk that our CDD patients share with them. So anti-seizure medicines, contractures, immobilization, low physical activity. And if they are struggling with nutrition, sometimes they don't have, I'll tell you, if we checked everyone in this room, I would guess probably more than half of us have a low vitamin D. It's just really hard to have a good vitamin D. And so often they don't have enough vitamin D or calcium intake. So this is something that we take very seriously in the clinic, and we do very close monitoring of calcium levels and vitamin D levels, just to make sure that we don't need to make adjustments or add supplements of any sort. All right, so in conclusion, GI problems are incredibly common in, that says Rett syndrome, sorry, CDKL5 Deficiency Disorder, and can be absolutely debilitating. These patients have difficulty feeding, can end up malnourished, often struggle a lot with constipation, and all of the other things that we just talked about. Many patients and parents tell me that there's a lot of concerns that you all have with your loved ones, but GI issues can rise to the top at times. And so for that reason, I do feel really strongly that a GI provider is an important part of the team in caring for our patients with CDD. All right, well, this was so much fun for me. This was such a pleasure. This is an amazing community. I have loved every minute of this conference, so thank you for allowing me to come and join you all and learn from you, and hopefully I was able to help answer some questions. I actually stuck to my time, so we have like 10-15 minutes for any questions that anybody has, anything that I can clarify or help answer. I would love to help. Yes?
Thank you. we, as many others, have GI concerns, and you mentioned dysphagia, which I don't think that I've ever had, but I've seen her to that. She's bottle fed with G2, so I've been very lucky because I'm trying to keep the G2 at bay, but she only drinks one bottle. And I'm wondering, in your experience, is this a functional deficit that if you continue to work or I mean, for us, we have a goal for purees things, but it takes so long, like a tablespoon of purees 40 minutes.
Yeah.
So it's really, and then you have to go back.
Yeah. Yeah.
So it's a little much. We haven't done that in a while. We did all kinds of trials over the years, and it never progressed.
Yeah.
Is that just a functional deficit that needs to stick to it? Is it, what would you say if somebody came to your office and presented this?
Did everybody hear that, or do you want me to? Okay, so I'll repeat a very short version of it. So she was explaining that for their daughter, she is fully bottle fed and is able to keep up with her nutrition with the bottle feeding, and she does have dysphagia, so that difficulty with chewing and swallowing. They've worked on it for a long time, on and off, and she can do purees sort of, but it takes like 45 minutes to get a tablespoon, and then they have to give a bath because more of it's out of her than in. Yeah, more is out than in probably if you're having to, yeah, exactly. And so the question was sort of, with this, should they keep trying? The way I usually approach this, so you're absolutely right. You're blessed that she's able to take everything she needs from a formula. So the first thing that I want families to know is that formulas are meant to be a meal replacement, and so it's actually easier to guarantee that a person is getting all the micronutrients and macronutrients and everything they need when they're on a formula than when they're eating, an unaffected child her age probably has less macro and micronutrient repletion than she does because of the formula, which is wonderful. Exactly. So yeah. So it actually, in that sense, and I think that there is sometimes a fear of but it's not real food, or it's not. And there are some formulas that are real food, but I just first want to say you can be 100% healthy on formula. And so the fact that she is able to, from a nutrition standpoint, there's nothing that she's lacking. From an oral motor skills standpoint, where I often do recommend, and this can be limited by location and availability of therapists and whether they've said, we've done what we can, there's a lot of things that go into this, but I think continuing to work on oral motor skills is always a good thing, because even if she's not taking anything pureed by mouth, she still has to manage her secretions. She's still going to have to swallow saliva. So the more we can kind of work on the functioning of the maybe not chewing as much, but swallowing and making sure that is a safe thing, it's beneficial to kids. And so while I don't think that I would ever say to you or a patient in my clinic in this similar situation, well, our goal should be that she takes all pureed foods, I think that's probably unrealistic and not necessary. It sounds like it would be a big burden on your family and on her, and she probably would start disliking food, and it becomes a whole thing. More just for as long as we can keep her practicing with oral motor skills, it's always a benefit as opposed to a negative. Does that make sense? Does that answer your question?
Yes, and thank you, because I feel like almost that reduces the pressure. It's not it's okay if you just swallow one or two little things at a time, then we don't have to really do the 45-minute thing. We can just, if we're ice cream, we can just try to make ice cream and see what happens.
And so most often my patients they will have kind of pleasure feeds where it's it's her birthday, yeah, she got a lick of icing and maybe a spoonful of ice cream, and but otherwise we're not really focusing on it because it is it's no longer enjoyable for her at that point when it becomes a forced thing, and it's no longer enjoyable for you either when you're spending 45 minutes and not feeling like you're accomplishing what you're hoping to accomplish. Of course. Yes.
Can I just say what I wish my doctor had said?
Yes.
So my daughter's 24, and she ate fine for a long time. She was and then we had some problems. I think that was medication based. Neither here nor there. She's now tube fed. But I remember when Olivia was maybe 3 or 4, the doctor said, you have an option on the G2. And I'm I was offended, and why would I ever do that? Because I have a big son, and I don't want to go that. But in hindsight, I wish they had explained better with, you don't need to feed with the G2, you can hydrate and medicate. I spent 18 years trying to get horrible medications in her mouth, and I felt horrible. And every time it's not good tasting stuff. tough.
It's not.
So, and the hydration, she was a good drinker, but not to the level that we need water.
Mm-hmm.
So I wish I had known then, I'd just use it for meds and water, and keep this liquid. She loves it. But now we're too fed, and that was a lifesaver for us now. We had that because I'm dehydrated then, but anyway.
Thank you.
It was a fear factor for me, honestly. See, and I always have that. See, that's really nice.
Thank you so much for sharing that, especially from a mother who has it. You're dealing with the G-tube feeds now. 99. I never say 100% because then I'll be proven wrong, but 99.9% of the time, this is the exact story that we hear. There is understandably a fear of change, a fear of it's a surgery. Like, I will never downplay that. But the pressure that comes off of the caregivers once the G-tube is in place can be immeasurable, just from the factor of they're sick. They don't want to eat. Okay, well, I can give them some Pedialyte through the tube, or, you name it. And then the medicines is a huge thing, not having to worry about how to give the medicines. The other thing that I mentioned, I will tell you, I almost never in my CDD patients place a G-tube and then remove it. But the other thing that I will tell families who are really hesitant is that placement of a G-tube requires surgery. Removal of a G-tube requires you coming to my clinic, me pulling it out and putting a Band-Aid on it. Like, it's very simple to remove. So even the idea of a G-tube, people see it as like a backstep or like a negative, or like they've somehow failed, but it can often be really, really life-changing in a positive way. And 99 times out of 100, families are very grateful that they got it once it's in. So thank you for sharing that. I really appreciate that. Yes, in the back.
Can you explain a little more about Symethicone?
Sure. You want me to is there a specific question, or just kind of how it's used, when to use it? Oh.
About how much do you need them?
So, okay. Yeah.
Did this come out? Or
Yeah. So the how much is tricky because it is in children, things are dosed by weight. And so from a medical advice perspective, I can't tell you how much, like dosing wise, but it can be given up to 4 times a day very safely. I typically will say if they're gassy, give it. If there's something that's going to make them gassy, give it. So if like when they get their evening feed, they're always super gassy, you can absolutely use it as something before they get their feed and then see if it can kind of help reduce the gas. It is a wonderful medicine, and that is a very safe medicine. There are not very many side effects. We give it to infants, right? It's not very many side effects that we have to worry about. It can work beautifully for some patients, and it does a little bit for other patients, and I think either way, if it's helpful, helpful is good. And so either way is fine. So I do have some patients who just routinely use it 2 or 3 times a day, like every single day. That's just because they know they need to. Other patients will, if they know that a certain meal of the day, a certain time of the day is the time when they tend to be the gassiest, they will give it preemptively, at 4 o'clock before their last feed. And then I have other patients who aren't needing it all the time. And so for them, I would say wait until you start seeing they're a little gassy and then give it. And so I think it's hard to say for any individual. It kind of depends on what works best for you and your loved one. But it is absolutely appropriate to use it kind of before a meal or before, you name it, whatever time of day that you find them to be the most gassy. And it's also okay to wait until you see they're a little gassy, they're tooting a little more and they seem uncomfortable, and then give it. Then it works relatively quickly. And so it is something that's fine to give once, kind of when they're symptomatic as well. Yes.
One more question.
Yeah.
Because I've never heard anybody talk about a diet before, but I noticed you said BMI over 85%.
Yeah.
What we're dealing with right now is early puberty, and she's grown enormously over the last year in height anyway, but I think her BMI might be around that. Anyway, she lets us know when she's hungry.
Mm-hmm.
We don't just feed her, but she's been hungry, and I hesitate. I don't even know how that would look like. She tells me,
Yeah.
her hunger cry, and I would keep her on a diet. So I'm just curious if you have any thoughts.
Yes. So when we say diet, I am always conscious of the idea of when we make changes, we don't want to make them hungry and uncomfortable. So with formula, for example, there are often reduced calorie versions of formula. So you can actually swap out like 1 feed a day with a reduced calorie version, and that brings down 100 calories from their daily diet. They don't feel any different because they're getting the same kind of similar to if we were. So I think as adults who go on diets, we're like, we're going to starve ourselves and that's how we're going to lose weight. It's not really the best way to, right? Like you ideally want to be, instead of a burger, you're going to have a salad with some chicken and some, beans and some other protein that will fill you up the same amount, keep you full longer, and be healthier and fewer calories. So we think of it the same way. Try to swap things out in a way that won't make them hungry. We're not just going to do water and expect them to be full for a long time, right? But we can make changes to the formula that will, or like subtle differences that they probably won't feel that over time will add up. And then often when we are trying to have patients lose weight, even once, like your daughter doesn't look obese, but even ones who are quite overweight, and we do need to, my goal is never, and I say this every time, I'm like, we're not trying to lose 10 pounds in a week. We're trying to lose 1 or 2 pounds in a month, right? Like we're trying to step it down. We have time. Like we want to do it healthy. We want to do it in a way that's sustainable. And so the changes that we make, just so you know how we think about it, we often, my dietitian and I will sit down and try and think of a way to reduce calories by about 10% if we're trying to have kind of a gradual weight loss until I see them again in 6 months or 3 months or whatever it is. If it's just mild changes, we're trying to kind of, they're going to continue growing, but we just want to grow a little bit less quickly. We might do like a 5% decrease, which actually ultimately doesn't end up being a very big volume change.
And would you do this even in periods of transition like puberty, or would you wait,
I would. If we see that it all depends on the rate of change. And so to your point, she's growing in height and weight, so it may not be that we need to do anything, right? Like we may just let her grow into this formula that she's on and the amount that she's taking. As you guys probably see over time, what she took when she was 3 years old versus 5 years old versus 10 years old versus 12 years old, we do make tweaks as they get older sometimes. And so maybe we would just hold on making an increase, and that's how we are decreasing, if that makes sense. And so there's different ways to think of it depending on where they are. I wouldn't allow someone to get overweight because they're going through puberty. I would probably make some tweaks, but I may not be as aggressive during that change.
And you are a GI specialist with a nutritionist who work in a neurology clinic?
So no, we are in our own gastroenterology clinic, except for our multidisciplinary clinic. I relocate myself into the neurology space for that, but we have our own clinic. We just are sort of under the umbrella. So all Dr. Suter, who you saw, all of the patients he sees, he refers to me. And so if they're not being seen in our multidisciplinary clinic, they will be seen in my clinic at some point with the dietitian. So I am fortunate to be able to see all of our friends with CDD, and then I'm fortunate to have a dietitian who's probably seen more under this Rett syndrome umbrella that our clinic has than probably any other dietitian in the world. So I feel very fortunate because she's just seen a lot, and we're able to kind of think a little bit uniquely about how we manage things for our friends with CDD, which is nice.
Do you guys ever work across state lines?
If you come across state lines to Texas. Yeah, I wish. I wish we could.